Hello, everyone, and let's try that again. Hello, everyone, and welcome. My name is Caroline Kohles. I'm the Senior Director of Health and Wellness at the Marlene Meyerson JCC Manhattan and the Program Coordinator for our Parkinson's Wellness Program, supported by the Neil S. Hirsch Wellness Fund and Northwell Health's Edmund J. Safra Foundation. And I'm joined tonight by our partner, Gloria Lebeaux, LCSW Director of Social Services at the Barry and Florence Friedberg JCC in Oceanside, New York. And I just want to welcome everybody to Building Your Team, how PT, OT, and speech therapy can empower us to navigate Parkinson's disease. Gloria and I will be joined tonight by Dr. Rosemary Gallagher, Professor of Physical Therapy at New York Institute of Technology, and Ling Wan-Albert is an Assistant Professor of Occupational Therapy at the School of Health Professionals in New York Institute of Technology and Speech, and language pathologist Orit Greenberg as well. But before we get started, I want to let you know that we consider you are a vital part of our conversation. So as we go through this talk tonight, really make sure that you put what you want, as Whitney said in the pre-game show that we had before we hit the record button, put your questions in the chat. And if you don't get them answered, reach out to Whitney or Gloria or Rose or any of us really, and let us know what your questions are, and we will get them answered, right? Gloria, oh my gosh, my dear friend, so lovely to see you. As a social worker, you're really a resource person to many. Can you talk to us about the importance of putting together a team of health and wellness practitioners for navigating Parkinson's, and why do people think they need to go beyond just their primary care physician and their neurologist?
Okay, well, first of all, thank you so much. I'm so happy to be here. It is wonderful to partner with you and Whitney and the Manhattan JCC. I think we've worked so well together through the years, and I hope we will continue to do so. I think that just a little explanation about Parkinson's. A lot of you know this, but I think it's important to understand sort of the origins of this and then why a care team is so significant, which of course it is. Parkinson's, as we all know, is a neurological disease. We know that for the most part, it is related to a lack of dopamine or loss of dopamine. And most importantly, it impacts everyone in a variety of ways. There's a whole array of symptoms, whether they're motor or non-motor symptoms. And already what we're talking about is that each person is uniquely impacted. That's the first thing that makes Parkinson's so complex and already tells us that we are going to need more than one person to attack it. And so, of course, we all know that the first line of defense is our neurologist. We all are aware of that. We need to go see our medical doctor, get diagnosed, have him help you coordinate treatment. But what we also learn, because of this full array of symptoms, that we're going to need what is called a care team. My favorite term is not a care team. I'm a renegade, as everyone knows. My favorite term is circle of support. What we need is a circle of support. And you know who's in the middle of that circle of support? You. You are the advocate. You are the person that need to make sure that you get the right team around you, and you have the right and responsibility to tell your physician, I need help. I need folks to help me with my variety of symptoms, which include, of course, mobility, range of motion, balance, activities of daily living, speech, swallowing, emotional regulation, cognition, all those symptoms. We need a variety of folks, many of them who are here today, who are going to help you approach all these various symptoms with both concrete ways of attacking them, be educated in how to approach them, how to manage them. So it's you and that full circle of support around you that is going to be able to create what, again, is called a care team or a circle of support.
Beautiful. And let's start in our circle of support with physical therapy. Many of us have heard of or experienced physical therapy, often referred to as PT. But let's bring out Dr. Rosemary Gallagher, or Rose. She is a professor of physical therapy at New York Institute of Technology in the Doctor of Physical Therapy program and a Parkinson's Foundation physical therapy faculty scholar. Welcome, Rose. Oh, do you need to unmute?
That would help, right? Hi, everyone. Thanks for inviting me to speak about the role of physical therapy for people with Parkinson's disease. I'm happy to be here.
What is physical therapy and what is it in a general sense? And why is it an avenue that people with PD should actually consider?
Great question. So, in general, physical therapists help to improve people's lives through better movement. And we do this by a series of steps. We do assessing people, so whether they're patients or they're clients, and we look at your movement, we look at your strength, your balance, your flexibility, and your aerobic capacity. And this helps us to diagnose movement issues because we're movement specialists. All right. We then develop a problem list, and then from that problem list we set goals along with our patient or our client, right? From those goals we develop a treatment plan that's going to reach those goals. All right, so we create a personalized program and to help the person regain their mobility, such as getting out of bed or getting out of a chair or walking, improving walking or walking a certain distance or riding a bicycle or getting back to golf or hiking or whatever it is they do. And how we do this is we do this through therapeutic exercises or exercises. So we give them exercises that improve strength, balance, flexibility, coordination, gait, improve heart and lung capacity. So maybe getting on a treadmill or on a bike or something like that. We also use techniques like massage, stretching, or joint mobilization, and that can help relieve some pain and also improve movement. And so using all of these techniques, we're in a really good position to help people with Parkinson's move better and live better lives.
And moving better is one of the essential survival techniques of our bodies, of being human. But what do you think people don't realize about physical therapy? In other words, when should someone go to see a physical therapist if they're noticing change in their walking or gait? Are you saying that these exercises can actually help someone navigate or improve their performance or their walk?
Yeah, so that's a good question. A lot of people don't know when to seek a physical therapist or another rehab professional, right? And a lot of times in terms of being diagnosed with Parkinson's, and a lot of you know this, is that you can have it for several years before it's diagnosed. And very often it's a significant other, a spouse or an adult child or a sibling or something that notices that you're moving differently, right? And they bring it up and say, hey, you're not swinging your your right arm as much as when you're, when you're walking, as much as your left arm. And so then you may go to the doctor and try to figure out what's going on. Hopefully, if you go to a GP, they will have an idea of what's going on, send you on to a movement disorders doctor, and then that person can really help you. So from there, a lot of times you're referred to physical therapy. So can a person go directly to physical therapy? Absolutely. In New York State, you can. We have something called direct access, which means that you can walk into the door of a physical therapy clinic and say, I would like to have therapy. I am having these problems. The only kind of caveat to that is that we can't guarantee that insurance is going to pay for those visits, but you can certainly submit the claim and or you can check with your insurance to see if they will pay for those visits. But a lot of people of a certain age, including me, already have doctors. And so any type of doctor you have, even the GP, and you can get a prescription written by that doctor to have you go to PT. So if you find that you're tripping on the throw rugs in the house a little more often, in the bathroom, in the kitchen, or something like that. You're like, what the heck? You know, or maybe when there's low light at night, you're getting up to go to the bathroom and you have a lot of, maybe have some difficulty with vision, but that's making the difficulties with movement even worse, right? And again, if you have a significant other, somebody that is near you a lot, they, like I mentioned, they notice that something's going on and that maybe you should get checked out.
Rose, we have a question in the chat by Dorothy. Can Rosemary talk about LSVT Big? What is it and who provides it?
Yeah, so really good question. And so I'm going to back up a little bit and just give a little background on cueing. One of the techniques, so one of the techniques that we use in treating people with Parkinson's, and very often, and this isn't just physical therapy, occupational therapy does it, and possibly speech as well, is we use cueing techniques. And there's three main cueing techniques that we use, 3 to 4. I'm going to talk about 3 of them. We talk about an auditory cue, a visual cue, and an amplitude cue. And so when we talk about, when we use these cues, what happens is that you use different pathways in your brain to get the movement, to get your movement. So you're using an auditory pathway that will circumvent your basal ganglia. So it won't go through your basal ganglia, which has difficulty producing dopamine. So these cues, they'll use these alternate pathways so that you can move better. And so we use these as a technique to get our patients to move better. And it can result in smoother and more consistent movement. The literature shows that cueing does work, but there's no one specific type of cueing that necessarily works better than another. All right. So you and your PT would decide, which is the best type of cueing for you. So with an auditory cue, we might use a metronome or we might use music, and this can help with your walking. So we can set a beat. We know that with Parkinson's, a lot of times people walk slowly. If we want to get you to walk faster, we might put on a metronome with a faster beat than what you're walking, or use music and headphones and at a beat faster than what you're used to walking and ask you to keep up with the beat. So that's auditory cue, types of auditory cueing. Some examples of visual cueing is we might in therapy put lines on the floor, pieces of tape on the floor, and ask you to step over them. All right. And that can help you take a bigger step. It can help you pick your foot up higher, possibly, so that you're not shuffling your feet. Some of you may use or have seen the use of lasers. Some people have a laser on a cane. There's canes that have lasers, and you can press it and it puts a line on the floor, a laser line on the floor rather than tape, and you can step over that. So you can use those laser lines anywhere. You don't have to be in a clinic or in your house with lines on the floor. You can use the laser. So that's an example of auditory and visual cue. Now, LSVT is known as an amplitude cue. So we're asking you to move bigger. All right. And it's also known as an attentional cue. So we're asking you to pay attention to the size of the movement that you're doing. So we're always saying, move bigger, reach further, and things like that. And if you've done LSVT, then there's very specific instructions that the PT or OT will give you to get you to move bigger. All right. And so LSVT or amplitude cues is just another cue that we know works in Parkinson's disease. And it happens to have kind of its own home, right? This LSVT, it's got a whole organization and things like that. It actually came out of, and Orit will know this, it came out of speech therapy, and then they modified it into movement. And so PTs and OTs adopted it for movement as well. So yes.
Wonderful. I seem to remember like one of the movements being really big, right?
Yes. Yeah. And the reason that works is that what we know about Parkinson's is that the brain has difficulty scaling your movement. So you might think you're taking big steps, or you might think your arms are way up in the air, or you might think that you're walking really fast, or in boxing, you might think that you're punching really fast and really hard, but you're actually not, because your brain isn't able to kind of integrate the sensory information coming in to let you know exactly how fast you're moving. And so when we say take bigger steps, you might be thinking, I am taking bigger steps, get off my case, right? But you're actually not, all right? And so so LSVT is one of those techniques that we can use to take bigger steps and try to get your steps to a normal step, maybe, or you're reaching to a normal reach, something like that. So
Awesome. We have another question in the chat. When in the course of the disease do we consider, or should you consider beginning LSVT big?
yeah, usually if you're going to do LSVT big, you're probably in therapy already, PT or OT, and that PT or OT may do some LSVT big exercises. Please know that LSVT, excuse me, is a very specific regime, and that you need to do it 5 days a week for 4 weeks. But you'll find therapists will use pieces of LSVT. So you might have a half hour, 45-minute physical therapy intervention or OT intervention. And part of that might be some LSVT big exercises. We are told by the LSVT big people that we're not allowed to call it LSVT big unless we're doing the 4 weeks, 5 days a week, but we call them big exercises. We're doing large movement, large scale, large amplitude movements. So you're usually with a PT at that point, and they may start it, or they may suggest that you do the full 4 weeks, 5 days a week regime.
Wonderful. What about balance and using, assisted devices such as walkers, canes, and rollators? I know many students don't want to use these devices, but when should someone think about incorporating these? And how do you choose? How do you know which one is the most appropriate?
Yeah. Besides gait is usually the biggest concern for people with Parkinson's disease. And there's been studies on that to show that is of all the problems that you might have, gait is always at the top of the list, understandably, right? Balance is way up there as well, though. And so in physical therapy and in community exercise programs, we spend a lot of time doing balance training with you. And we can, if we feel it's appropriate, we may suggest that you get an assistive device. An assistive device can be a cane, it can be a walker, it can be a rollator. What we know about Parkinson's is that people with Parkinson's don't lose the ability to move. They lose the ability to move automatically. That's what the basal ganglia does. It helps us with automatic movement. So we learn a dance step, right? And we're concentrating on it, and we're looking at our feet and things like that. But once we've done it enough, it's automatic, and we just do the dance step. We don't have to think of where our feet are going. They go in the right place. But with Parkinson's, you lose that ability to move automatically. So we like to go more towards rolling devices. Yes, you can use a cane, absolutely. If you get just little bits of being set off balance every so often, the cane may kind of catch you. But if you need more help with the balance, we like to use like a rollator walker. And those are they're usually colorful. They're red or they're blue or something like that. They have a seat that folds down, which is nice. They have brakes on the handles, and they have 4 wheels, because we want to encourage the automatic movement and keep moving in Parkinson's. So we don't like a standard walker, which doesn't have any wheels on it. And you have to pick it up and take a step, and then pick it up and take a step. That feeds into the lack of automaticity and movement. We want something with wheels that's going to keep you going and have the brakes on there that you can always put the brakes on if you're getting to go too fast, or we have a seat. There's a seat if you get tired and want to sit down.
Speaking of fatigue, I know a lot of my students will talk about how they just feel tired or their legs feel heavy. Can you speak to that?
Yeah, so that's going to be more some of the heaviness feeling, and actually we get that in people with multiple sclerosis as well, is that's more of a sensory type feeling. I'm not going to speak to fatigue because Dr. Albert is more of an expert on the fatigue piece than I am, and I think she's going to mention that. But that's more of a sensory thing, and it's like internal, like I know some people get these internal tremors, right? And sometimes the medications will help with it, sometimes it won't. That fatigue could just be that maybe you're not moving around as much anymore because it's difficult to move around, and then you get out of shape. And then when you do try to move around, you're getting tired or something like that. So.
Oh, Rose, thank you so much. We have one last question that is in the chat that I want to make sure we get to. If you're going to do LSVT for speech, will it help for movement, or do you need to do both separately? And is LSVT big any better for cueing than other types of cueing?
Yeah, good question. And so whether LSVT big is better than any other types of cueing, no, the literature says that any of those types of cueing, the auditory, the visual, the attentional, and actually there's a somatosensory or a touching type cueing, they all are effective in working with people with Parkinson's disease to reduce motor severity, to improve their movement and their functional capacities. So you would choose what you think is best for you along with your healthcare provider. In terms of will the speech LSVT help the movement? No, no, they're kind of two separate things. So yeah.
Well, let's bring on, we were talking about fatigue, and I know that's a big topic. So what you have talked about is so helpful. Let's bring out your colleague, Ling Wan-Albert, and so we can talk about that and we can address that. Ling Wan-Albert is an assistant professor of occupational therapy at the School of Health Professionals in New York Institute of Technology. And she has over 18 years of experience in adult physical rehabilitation and has been specializing in Parkinson's care for over 10 years. Ling, welcome.
Thank you so
nice
much
to
for
have you
having
here.
me. Nice to be
Yeah.
here too.
First of all, what is occupational therapy and how does it differ from, your colleague Rose and what she does with physical therapy?
Okay, this is a question that many people ask. They're like, do you help people to look for jobs? I'm retired. No, occupation itself is things that we do in our everyday life. Well, a career, a job, a profession, that is definitely an occupation. But also everything that we do that is necessary to maintain our everyday life. Sleeping, starting from sleeping, right? People think that, oh, sleep is like you're not moving. Now, sleep is a very important occupation because if you don't sleep, you cannot do any other things. We call that activity of daily living. So while there are some overlaps between physical therapy and occupational therapy, in focusing on improving posture or using exercise to improve movement or mobility, occupational therapy or OT focuses a lot more on the outcomes of independence and safety of performing activity of daily living, such as eating, grooming, getting dressed, bathing, toileting, bed mobility, chair mobility, getting in and out of the shower, handwriting, that is a big complaint with clients with PD, trouble with their handwriting. We also look at the cognitive components. Are there any issues with memory, planning for the day, sequencing, making decision, time management that affects their everyday activities of daily living or things that they need to do that are important in their roles. We focus on what their roles are in life. Are they still working that they need to maintain their career? Are they a wife or husband, mother and father, daughter and son of their older parents that they need to take care of, their roles in the community. We also look at any psychological or psychosocial components that affect their roles or their ability to perform these activities of daily living. Are they experiencing some depressed mood? lack of motivation, or general physical or mental fatigue that might be affecting their ability to perform all these important things in their life. So there are a little bit of overlap between PT and OT, if I answer your questions, but we look into all the possibility that might affect their ability to maintain quality of life.
I know my dad wanted me to ask, will an OT help me improve my bridge game? My
Yes,
mahjong?
absolutely. Absolutely. So you will see an OT to do an individual evaluation, have the OT look at you, play half of the game to really look at what might be affecting you. Is it your ability to pick up the pieces or moving the pieces or the timing or sequencing? Is it hand tremor? Is it fatigue? Do you need a rest break? So all these components that affect someone's ability to play a game.
That's awesome. We had a great question. Is it important to have PT and OT simultaneously, meaning one session each in the same week? Also for speech therapy, which we'll get to with Orit, is it important to use something like Speak Out, or is merely reading anything out loud good?
So
And she's already, go ahead.
Okay, I will answer the first part of the question and leave the speech question for the experts. And so is it important PT and OT happen simultaneously? I'm going to say not necessary, but it is also beneficial if you receive PT and OT inside one facility, that the PT and OTs can communicate with each other. So I speak to my PT colleagues. So maybe we are sharing one client, and then we kind of, pick on each other's brain. Hey, I have this client. Remember, she has this and that and that. What do you think? Right? So we kind of exchange information, put our brains together to really help the clients to maximize the outcome and the benefits. So there are definitely benefits when you have PT and OT at the same time. But otherwise, I'm going to say it's not necessary or important. Whatever is realistic for you, right? You prioritize what might be the more urgent needs. Maybe your walking, your community mobility is more important. Then do PT first, right? Be realistic about your time, and then later on you can pick up OT to work on some other activity of daily living problems that might be bothering you.
Yes, Gloria, I'm reminded of what you said about the circle of support, right? And to use an OT and a PT, and to remember that ideally they're talking to one another so that we can brainstorm, because everyone is an individual and there's not like a cookie cutter solution to each individual problem, where somebody might want to improve their bridge game, somebody else might want to learn how to pick up things off the floor. What about gadgets and resources that might help someone with PD actually remain more independent?
Great question. So your occupational therapist will first do an evaluation to really determine what might be the baseline problems that you have difficulty or challenge doing X, Y, and Z. He or she may determine using a more, we call that restorative approach, using exercise, focusing on improving movement before suggesting using adapted equipment or what you call gadgets, right? But we also want to get the balance if it is really too challenging for our clients to improve their strength or their movement. And sometimes it doesn't happen in 1 week, 3 days, right? It takes time. So perhaps we might also, you know, look at your situation and suggest certain things. Okay, in the meantime, perhaps you can use some common examples will be eating, have trouble holding the spoon, the fork, or using the knife to cut, right? Eating is a big part of our culture, right? And also maintaining life too. Having trouble eating is really a frustrating thing. So I might see, okay, use we call that built up utensils, meaning that they are still spoon, fork, knife, but with a large handles. Some people may ask, well, would that help using the weight utensil? They are heavier, right? So there are mixed message in the literature. At one point, scientists said, no, it will cause a lot of fatigue in the hands because they are heavy. After a while, they just stop using them because they are just too heavy. Think about you are carrying like a quarter pound just to scoop something in your mouth, right? But at the same time, there are people who said it really helps their trauma. So it sounds like it helps for a short period of time, but for a longer period of eating, it may, you know, give you some hand fatigue. So like depending on the clients, right? Another common gadgets that I usually suggest clients to use because it's just very hard to regain those ability is any kind of like a can opener, jar opener. We can strengthen hands and arm as much as we can. Be honest with you, sometimes I have a hard time opening jars and bottles, right? So these type of things, I'm like, you know what? That's enough to struggle in life. It's okay to use some of these gadgets, right? Kind of get a balance.
Thank you.
Someone has the mic open, maybe. I'm
Yeah.
going to say handwriting. Handwriting is another big problem, right? People complain about. A lot of my clients share with me that, you know, we tried out, see if that helps first, that hands that give you a big grip is almost like holding a soft ping pong ball so that they are not like you know, holding a pen or pencil that skinny, right? Instead, they are kind of like holding a medium-sized ball that they seem to gain more control and movement. And when you see an occupational therapist, we will try to use different methods to see if you can improve your handwriting. To help you find an effective way to cue you to be able to write larger. Clients tend to write better when they write online instead of a blank sheet of paper for that visual input and guidance. So everyone is different. This trick may work for this individual, may not work for another individual. So the OT can really figure out with you what works best for you.
Customize it. We have a few questions. One is about sleep. REM sleep behavior disorder. As we have PD, I move while I sleep, so much so that I've fallen out of bed 33 times since June while streaming, and I've already doubled my medication to stop that. What options do I have with OT? Is that something an occupational therapist could help me with?
It's very difficult, I can see. I'm going to say make sure that you will put up a bedside railing, something that you can actually install and have that put up at the side of the bed, that you can also put down easily. Or you can actually see which side you tend to fall to more. Some people have a more tendency to fall to the right, more tendency to fall to the left. So definitely that side, you might want to have your bed either against the wall or, to have a railing next to it. I always, so the REM sleep behavior disorder happen, right, when you're in REM sleep, the deep stage of the sleep. And there is not a whole lot we can do from the occupational therapy perspective, but I have been teaching my clients to do some relaxation exercise for breathing, for their guided meditation, very general stretching that may, kind of relax them a little bit. And some people find that they have a better night of sleep, but I am not sure if that will help any of the REM sleep disorder.
And we're really talking too about it, how an OT and even a physical therapist, and we're going to get to Orit next, we're going to talk about speech in just a moment, can come to our house and visit the home and do an assessment of the home. So it's not just doing an assessment of you, it's doing an assessment of your environment as well. Is that correct?
Yes, absolutely. So PT and OT can go to your home to really see your environment, see if this is a safe environment for you, and make recommendation if there are any changes may be necessary to improve your independence, your safety, and your overall quality of life, and perhaps more independence in general. We can assess the bathroom situation, or if someone started using a walker, we might make recommendation if there are certain angles it's very hard for the clients to make turns to, or the method to get in and out of the bed while you are using a walker. Maybe practicing, this is where you sit down, this is where you move your walker forward this way so that it won't be in your way if you need to get up to use the bathroom in the middle of the night, so all this planning. We can also set up, we call that home exercise stations, right? And so maybe this chair is your leg lift chair. And then at this part, we also set up therapy band that when you sit in this chair, you have to do 3 reps of 10 of therapy band to improve your posture, right? Maybe this is the spot at the end of the kitchen counter. You are going to hold on to a counter and do your leg and your squat exercise. So we look at, your home environment in general, if there are any change that we will recommend to improve your safety and function, and also potentially make you do exercise in your own home.
I love that. I love that you're creating great habits as well.
Yes.
So speaking of habits, the way we talk is very habitual. And sometimes we don't even realize that our speech is changing. So let me bring out speech pathologist Orit Greenberg, and she's going to provide us with a look into how she provides individualized evidence-based therapy for voice, speech, upper airway, and even swallowing. So important. Orit worked at Montefiore Medical Center, the University Hospital for Albert Einstein College of Medicines, and the Children's Hospital at Montefiore before going into private practice, where she is certified and licensed to practice in New York and Pennsylvania. Welcome, Orit. I know people have a lot of questions about speech. It's part of our personality. It's the way that we connect with one another. It's so crucial. And sometimes, to have somebody say to you, I can't hear you. What did you say? Can you speak up? Can be so disheartening. So I'm really excited to have you talk. What is it exactly that a speech pathologist can do for us?
Thank you so much. I'm very honored to be here, and my esteemed colleagues. I hope all your burning questions are being answered, and please interrupt me if there's any burning questions. A speech language pathologist prevents, diagnoses, and assesses speech language, social communication, cognitive communication, and my specialty, voice, swallowing, and upper airway disorders. Voice is right. It's your fingerprint, right? Everyone has a different voice. That's why we have a lot of voice AI things, if you want to call your bank. And swallowing is swallowing your pills, your saliva, solids and liquids. And upper airway disorders could be breathing issues, coughing, throat clearing, some things that unfortunately come with the progression of Parkinson's disease.
Yes. So when we began planning this conversation, you mentioned to us that speech pathology is more than just learning how to talk louder, which is often a challenge for people. What do you mean by that?
So breathing is critical. So like I mentioned, speech language pathologists can help you with breathing, which is in the hierarchy of things, the most important thing. We want to make sure that you're breathing efficiently. Then swallowing, right? Swallowing issues, even though you might not be aware, sometimes you drink or eat something is a sign of penetration or aspirate the wrong way. Hopefully you have a nice strong cough and you can cough it out. But unfortunately, sometimes even as we age, even without a disease, we're kind of not as sensate and our muscles aren't, we're in our 40s. And things can go down the wrong way. If you're healthy and you're moving, your body can usually fight it off. You don't get an aspiration pneumonia. But sometimes we're not. We're a little not as sedentary, and then that's when we can get in trouble with an aspiration pneumonia. You don't want anything in your airway other than air, not saliva, not bacteria, not the pill, not a chip. So swallowing and voice. So in order of hierarchy, breathing, swallowing, and then your voice. And sometimes that's frustrating for people because the voice, like you said, is the way we communicate. And it's not the most critical thing. And sometimes people aren't breathing or the swallowing issues, but we really need a beautiful concert. It's a choreography. Everything has to work in concert, breathing and swallowing, breathing and voicing. And it's amazing that those 30 muscles, 30 to 60 muscles, some of the same ones for swallowing and voicing, work beautifully. We find there are problems when something is discoordinated.
Yes. So we're having a little trouble, I think, with me and maybe with you, going in and out. But could you give us a breathing exercise or show us maybe what one of the things that you might do in a session?
Yeah. So I apologize for any technical issues. We want to make sure that we are maintaining your function instead of on the line to try to regain function. So I want everyone just to kind of feel their Adam's apple and go ee. So going up in pitch like a tea kettle. E. Beautiful. And now I want you to pay attention what your Adam's apple or your larynx is doing when you go up in pitch. E. It kind of raises. And now I want you to swallow. So just swallow. And your larynx does the same thing. It kind of goes up, front and down. So some of the things we do in for people with Parkinson's, if this is one of their issues, is we do pitch glides up. And not only does that help with your voice, it helps with your swallow.
Wow. I want to just bring everybody back in and talk about the gains of early intervention. Gloria, can you pop back on and just tell us about how important it is when you first get a diagnosis to create your circle of support?
I think it's terribly important. I think the problem is that we go to the doctor and often we go and don't know what to say and don't know what to ask. And I think that's probably the hardest thing that happens when you initially go to a neurologist. You're overwhelmed. You know something might be wrong. You don't know exactly what it is. And you know nothing about Parkinson's disease. First of all, you don't even know if you have Parkinson's disease. Then you don't know what to ask about Parkinson's disease. So you're really at a disadvantage. And it is just, it is so important at the moment where you get a diagnosis to start getting informed. It's terribly important to get informed, to go to a neurologist that you can say to him or her, I need referrals for my mobility. I'm having trouble eating. My brain is really foggy. I'm having trouble swallowing. What do I do? It is really incumbent upon them to make referrals for you and to give you recommendations. And that is a right of yours. But unfortunately, we can't always assume the doctor is going to be the one to say it. We can hope, but it is really your responsibility and your privilege, and you deserve to have referrals to those people, because as you can see here, this circle of support that we're describing is invaluable. This is what is going to help prevent progression. This is what is going to help maximize quality of life. This is what's going to make the journey doable, particularly in those initial years where you might not even have so many symptoms. So it's the time to really boost all of these providers and really use them and rely on them. I would include in that social work. That's the time. And that is also a person, if I may say, if you're having trouble navigating, getting all these people, you go to a social worker. You know, one of the things we're good at is finding people resources, or you go to someone like Carolyn or Whitney and her team, and they will make connections for you, because being connected to really competent people who care about you and care about your journey is really, really important.
We had someone in the chat share that she went to an occupational therapist for rehab before she started her PD meds. And now those OT issues that I have greatly improved since being on meds. And her question is a good one. Is it a good idea to continue doing the OT exercises for muscle memory purposes? Ling, what do you think?
So I think it will be beneficial to revisit the service that you had in the past, as long as you find that there are still areas that you want to work on and improve, because of the progressive nature of the disease. There's always changing, right? So I think when you go back to the therapist and then, have another evaluation, and maybe there are things that you did not have to work on before, now you have to work on. Or sometimes patients just want to keep going as long as financially makes sense, insurance coverage is, okay with them. They feel it is part of their life already to keep things up and stay on top of their routine, their exercise, their movement, the things that they need to work on, things that they need to be reminded on, problem solving skills, and clients always find something new to work on. I find that for recurrent clients.
Great, thank you so much. Can Orit explain how the pitch glides up also help with the swallowing? fascinating. Would doing that and other vocalizations lead to cumulative benefit that typically lead to moderate or greater improvement that lasts, or typically, when done daily, just prevent the voice and swallowing issues from getting worse sooner rather than later?
Yeah. So, like everyone's mentioned before, it's very client specific, right? Your deficits are different than my deficits. Windfall gains, those upward pitch glides definitely help your slow and the voice. So it'll help with intonation and inflection. It'll help with animation. So there's different windfall gains, but we'd have too little time to get into all the nitty gritty. But yes, there are definitely exercises and strategies that help across different breathing, animation, right? I hope you could hear me okay.
So I believe what I can paraphrase it a little bit is that those glides, oftentimes what happens in Parkinson's is that someone has kind of more of a monotone voice, and those glides help add some variety, some resonance, some even expression in the face, and strengthen those muscles quite a bit. Rose, I wonder if you could say, I know you answered it in the chat, is there a difference between the training between a physical therapist and an occupational therapist? And what is that?
Yeah, as Ling mentioned, that there is overlap between the two professions, especially in an inpatient setting. So if you're in a hospital or nursing home or an acute rehab, you might be evaluated by a PT and OT at the same time. And then we speak with each other to, to work on common goals together. That's going to help in both the occupational therapy area and the PT area. So the education, the physical therapist, the entry-level degree is a clinical doctorate of physical therapy, similar to a law degree actually, and a pharmacy degree, doctor of nursing degree. And then the OTs also they still have their master's, I believe, correct me if I'm wrong, but they also have an O.T.D degree, which is that Doctor of Occupational Therapy degree also. So if you do the doctorate degrees, the clinical doctorate degrees, not an academic doctorate, you would usually do 4 years of undergraduate work and then 3 years in a doctorate program of physical therapy and with an OT. And within those programs, you have many, many weeks of clinical rotations where you're in a clinic and working under the supervision of a PT or an OT.
Wonderful. Gloria, let's talk about the family. I think maybe it was Rose that said sometimes a significant other or a friend might notice that your walk or your gait is different. How can we work with our families, or can the families sort of help us guide towards an OT or a speech therapist or a PT? They might notice it before we do.
Yeah, I mean, I think that in most situations, but I think in Parkinson's in particular, that relationship between the care partner and the individual with Parkinson's is a strong, and it's viable. And oftentimes it's the caregiver, frankly, that we have a lot of contact with. And of course, because we're often dealing with a mood dysregulation with someone with Parkinson's. So if we're dealing with depression or we're dealing with apathy, they are often not able. And as people use the word unwilling, and I cringe. It is not unwilling. They are unable to ask for assistance or to say, I need this, because, the dopamine strips that ability as well. And it really creates this kind of inability to sort of propel themselves forward or to motivate themselves. So often it really is the care partner, and they can be instructed how to be motivating, not how to nag. That's a different word. How to be motivating to get someone to understand that there is help out there, that the symptoms they're experiencing that are so frustrating or disabling can often be helped. So, so it's important to have that relationship, and for the therapists, for a social worker, and I'm sure they're already doing this, to be engaging those partners, to be real partners. So that's the truth of it, that this all has to be a partnership. Again, we're talking about that circle of support. They are part of that circle of support, and we want to engage them.
This is a question for both Ling and Rose, and it's in relationship to sedentary lifestyle, right? And how fragility can creep upon us so fast, and it can impact both the likelihood of a fall risk and also fatigue. Is it true, Ling, that if I sit too much, even if I love to read, that I'm actually weakening myself and making myself more susceptible to a health risk, really?
I'm going to go first, Rose.
Sure.
I'm going to say, I'm going to look at it different way. For a healthy individual without a neurological conditions, we might be okay to sit for a few hours, read a book, right? Binge Netflix or movies, and then we get up and we are okay. We might be, oh, I need to stiff, just stretch. Okay, 2 minutes later, I'm back to normal, right? For someone with a movement disorder, I think the important thing is you want to remind yourself to periodically exercise your brain, to teach your brain how to move your body. It is scientifically proven that exercise can maintain or even slow down some of the symptoms of Parkinson's disease. And if we really believe that the more we move, or we actually now talking about vigorous exercise, right? Exercise that will increase your heart rate to a moderate to high intensity level. Then exercise really helps with your Parkinson's symptoms. Therefore, to answer your question, sitting a lot, if we are Asian, sitting a lot, even like that, if you look at normal Asian studies, right? Strengthening, weightlifting among older adults actually give you better lifestyle and quality of life, better heart condition, more normal blood pressure, and all those good stuff, right? So I'm going to say yes. If you have PD, or if your loved one have PD, focus on moving. Don't even entertain the idea of, what if I don't move much? Is it really true that I will decline? Yeah, I'm going to say you are in a race. Either you move or PD symptoms get you faster.
Could I say something to that as well? And I think the other flip side of that is that moving also impacts brain health. And so if we're talking about trying to head off cognitive impairment and want to retain executive functioning, movement, and again, real heavy duty conditioning is fabulous. But even if you can't, if we're talking about getting fresh air and taking a walk, anything that piece of exercise already will impact brain health. And so again, with Parkinson's, you're fighting against lots of various symptomatology. It's the physical symptomatology, and it's the cognitive symptomatology, and it's the emotional dysregulation. It helps with depression. It helps with mood. So we're talking about movement as being really healing on all levels, actually.
Absolutely. And just to add in a couple of things. One is that when we talk about aging, we're all aging, right? We talk about there's this a guy named Fried's frailty scale, and they talk about having enough reserve and cognitive reserve, but also physical reserve, so that if a health incident happens, like a fractured hip or something like that happens, you had the more reserve you have, the better off you are in recovering from that fractured hip or whatever it is that you're having. So that's one reason to keep moving, keep strong, right? So that when something happens, you can hopefully fight it much better and not become frail. The other piece of it is I'm taking a little bit different tact is I'm going to talk a little bit about fear of falling. And so what happens a lot in Parkinson's, we know that balance is a big issue. And so when you fall a lot, you may stop moving more. You figure out that, well, if I stop moving so much, I'm not going to fall so much. And so a lot of times we have people come in and we're doing an evaluation on them. We ask how often they fall. They're like, oh, I don't fall. And I'm like, wow, that's really, I'm thinking to myself, that's really interesting because they've had Parkinson's for a long time and many people with Parkinson's fall. But then I find out with more questioning is that they're not moving. So they get up in the morning, they go to the bathroom, they go into the kitchen, they eat, and then they sit and they're in the den all day long. They're not going out for walks anymore. They're not going out to dinner anymore. They're not out in the community and things like that. And the problem with that is that now you've made your life so much smaller, right? And your quality of life diminishes. All right. So a good reason to get out there. And if balance is the problem, your fear of falling, and that's why you're not moving so much, then that's an issue that you should address and get out there and live your life. There's so many things that people with Parkinson's can do. I mean, I run a hiking group for people with Parkinson's. I go backpacking with people with Parkinson's. Some of the people in here, Randy, has been my backpacking partner. And so there's so much you could do. You might have to modify it a little bit, but that's okay. Modify it and still get out there.
I also wanted to put in, Orit, I know you moved. Do you want to try and see if that works or you want me to read it?
I think I knew the group.
Oh,
so hopefully
I better
read it, but is that better? Okay.
Voice therapy isn't strengthening the vocal cords. It's recalibrating the system, working on strengthening the respiratory muscles, breath support, and respiratory drive so that you can be heard and be understood. So speak loud. People with PD think they are speaking loud enough, but they are not heard. They feel like they are shouting when practicing, but they need to increase their oomph. 10 by 10 effort. Speak loud, speak out, as someone mentioned earlier. And the pitch glides help with intonation and reduce the monotone voice. Sometimes people have festation with their voice, which some people think is stuttering. It's not. It's something else. And the voice therapy and speech therapy can really help that. She also said, move it or lose it. So that's why programs like Dance for PD or Sing for PD or, the programs that we have at the Friedberg JCC and the JCC here in Manhattan help so much. Someone asked, is there a connection between dementia and Parkinson's? Who would like to take that?
I can take that just briefly. And so, yeah, we talk about Parkinson's and there's motor symptoms and there's non-motor symptoms. Cognitive issues are part of the non-motor symptoms. We do find, not in everybody, because you see one person with Parkinson's and you've seen one person with Parkinson's. There's so many different symptoms. Not everybody has the same symptoms. So I'm not saying everybody is getting this, but in some people, there is a cognitive component and there is a dementia component. They call it, Parkinson's dementia component. And it's typically later on in the later stages of Parkinson's. So yes.
And I wanted to address the nutrition question. Who would help us? I know that an OT can help us actually make a map of the grocery store, but does OT help at all with like looking at meals or is that in another part of our circle of support in the nutrition end of things?
I'm going to say if you need very specific dietary recommendation, you should go to a nutritionist or dietitian that really understand Parkinson's disease or how Parkinson's symptoms affect gut health, to really get recommendation. If you kind of know or you have a good list from the nutritionist, but you don't know how to incorporate that in your everyday life realistically, OT can help with the life planning. But if you are talking about what to eat, you need to go to the experts.
We have a great
and I just
question.
yeah, and I just have to say
Sure,
about
go
the nutritionist. I got to say, I have trouble finding a nutritionist that knows Parkinson's. I know nutritionists, and there is one here at NYIT that she has spoken to some groups that I've been involved with, but I find it really hard to find a nutritionist that knows Parkinson's, because we know that there's sometimes a problem with the time you take medication and your meal time, and it's a very fine distinction. And I have trouble finding people. I can't even help you guys with that, because I
That's
can't even
our
find
next
some-
lecture series. Clearly, that's
Yeah.
our next lecture. The other thing that's
It should
tricky
be.
in that regard is, especially as we get older, it's a recommendation to eat protein with every meal, or at least some. And that's hard to do with the medication that people are on for PD. So that is a real challenge. We have two questions. What happens when your PT visits expire? 25 visits with Medicare. And how do we get extensions of insurance?
It's terrible. So in PT, we kind of like play a game almost with insurance. And so if you have a certain amount of visits that are allowed to you, a lot of times if the PT knows this and knows Parkinson's, then they'll know to spread those visits out. So the first week, they might see you 2 or 3 times, but after that, they may see you once a week. All right. And they may only see you once a week for the next 2 weeks, and then say, okay, you go home, you do all these exercises, things like that, come back in 3 months and let me check. And so we have different ways that we can work with, that we can kind of trick the system and getting those visits to be spread out more. Getting more visits is really tough. If there's a comorbidity or another, something else happened, you fell and sprained your ankle as well, then you can come back for the sprained ankle, and we can kind of treat the Parkinson's at the same time. So we have to be very creative in how we treat you guys, and how we try to get as many visits as we can. And it's unfortunate, the Medicare itself, it doesn't pay for maintenance therapy. And the problem with people who have a degenerative disease is that, so maintenance therapy just means the person's going to kind of stay where they are, which for a degenerative disease is a really good thing, right? You want you to stay at least where you are and not get worse. But Medicare doesn't pay for maintenance therapy. So unfortunately, what happens is you get some therapy, you go home, yeah, okay, me too. I get a little lazy on my exercise, whatnot. I get worse, and then I get worse enough that I'm falling or something, and then I have to come back. And now we're starting from square one again. Whereas if they would let us keep you for maintenance throughout the year, and keep an eye on you, then maybe this wouldn't happen, and you wouldn't be on this roller coaster of doing okay, getting worse, then going to therapy, doing okay, getting worse. It's really a tough thing, and it's our medical insurance world is not good for degenerative diseases.
I'm going to add a little bit that there's another trick some facilities do, at least sometimes we do, is to have the client start with physical therapy, and then as they are about to run out, and we plug the clients into occupational therapy, so that at least they have something to continue getting, maintaining, improving. Or sometimes we kind of like really, if the center or the facility that you belong to, if you are already receiving services, perhaps they have some sort of kind of like a pay out of pocket program, like, so kind of it won't go through Medicare Part B. It will be like you still go for the kind of partial maintenance physical therapy, and then you have used up all your PT visits. but you know what exercise to do. But you still get to the place to see the PTs. If you have questions, you have specific things that you still want to seek advice, right? So kind of like a wellness program, we call that in our facility. So a lot of places are doing that. And because it's so important, you know, to help you maintain, right? We really don't want to see you because you drop out of the, not drop out because you use up all your Medicare benefits this year. We don't want you to lose everything that you gain. That's why we work hard to provide kind of like a community-based exercise program to help our clients to maintain as much as possible.
Beautiful. This has been such an informative evening. I want to say thank you to each one of our presenters tonight, Dr. Rosemary Gallagher, Ling, Wan-Albert, and Orit Greenberg. And of course, special thank you to my partner, Gloria Lebeaux, for co-sponsoring this event tonight. And to the amazing Whitney Chapman, who's been in the background here, managing the chat and organizing tonight's event, writing the script, doing all kinds of things. And I just want to reassure everybody that if you missed something, don't worry, because we will be sending out a recording of tonight's event to all of you who signed up, and we will include the information from the chat so that you will have it, along with the contact information for all of our presenters. And I just want to thank everybody so much. We had a great time. We weren't sure how we would get it all in, but I think we covered a lot of ground, you guys. And I just really thank you so much.
Thank you so much, everyone, for being here and for collaborating together. It's wonderful to have these kind of collaborations, and we hope to do more, right, Carolyn? Hope to do more collaborations because that's really wonderful.
Yep.
Yeah, it sounds like we need to do something on nutrition.
That's next. We gotta talk. We gotta chat.
Thank you.
Everyone.